Hello, hello, hello. We are in chapter 23, Toxicology. And this is a very interesting chapter. And we're doing a combined effort again today with advanced EMT and EMT alike. Because to be completely honest with you, the fundamentals are going to be that are going to be the same across the board. And one of the first things we talk about in toxicology is just recognition and management. Carbon monoxide poisoning is probably one of the number one things that you're going to run into as far as something that's inhaled. And then, of course, there's nerve agent poisoning that you may see. How often do we contact our poison control? And then, of course, our AMP on every single one of those. Okay, so getting right into it, EMTs not so much, but definitely AEMTs. I'm glad you're not getting attacked by bears now. Advanced EMTs treat patients who have taken drugs of abuse almost daily. And of course, that's going to be your alcohol, your illicit drugs, and benzos and opioids. Okay. So when we see these, and of course, our other illicit drugs like heroin, ecstasy, there's a whole bunch of other ones. Okay. Obviously, cocaine, blah, blah, blah. And so when we run into these people that they overdose on these medications, we have to be able to figure out how to reverse that effect. And in some cases, if we can't, that's to the detriment of the patient. So we have to be able to recognize these immediately and know what's going on. So definition of a poison is toxic by nature, naturally, and it doesn't really matter what the quantity is. When it's toxic, at minimum, it's going to make you sick, and at worst, it's going to kill you. A drug can have some therapeutic effect if given in the appropriate circumstances and dosages. Now, any overdose is a toxicologic emergency. And that's what we're really going to talk about tonight, okay? So we're going to go into this a little bit further. Toxicology is the study of toxic or poisonous substances, and you have intentional and unintentional toxicological emergencies. So give me in the chat. Yes, thank you, Lindsay, for the poison control number. Absolutely. Go ahead and put in the chat for me. Give me some unintentional toxicological emergencies that you guys can think of off the top of your head. And it can be anything, okay? Anything at all. You don't have to be super specific, but any intentional. It's an accidental overdose. Tell me just a few of them real quick. And you may even have inhaled fumes from painting without proper ventilation. That's a good one, Lindsay. Another one is inhaled fumes from cleaning without proper ventilation. Okay, thank you, Deborah. Ammonia leak, that's another one. Right now, Deborah, I'm asking everyone to put in the chat, what are some unintentional toxicological emergencies that you can run into? And you guys, I'm here till 10. Now, we can get out of here at 7:30, but we can be here till 10, so y'all come on. There you go. Cleaning with ammonia and bleach. That's really bad, James. We don't like that. Taking insulin more than once a day. Actually, there are people that take insulin multiple times a day, but if you take more than the prescribed dosage, then that can be an unintentional overdose. So that's really good. Yes, absolutely. Carbon monoxide poisoning. So very good, guys. All right. So moving right along, you can find these everywhere, right? Wild mushrooms. Okay, improper BSI on first responders. Yeah, absolutely. You go touch something and it absorbs into your skin. There you go. Elderly taking more medication because they forgot. You know what, Lindsay? I'm going to go ahead and tell you guys, this is way off topic. I actually had gestational diabetes out of the 3 times out of the 4 times I've been pregnant. And I thought it was realistically the most ridiculous thing I'd ever heard in my life when someone tells me, I took my insulin, but I forgot to eat. How ridiculous is that? Until I hit my nesting phase and I did the same thing. And my blood sugar was low and it was orange juice with sugar was the only reason it didn't pass out because I was at home alone with my toddler. So these are things that absolutely do happen. So it's not just elderly, it can be absent-minded people like me. Fentanyl is another one, Mark, absolutely. Yeah, it wasn't good. Your emergencies can also occur from neglect, oversight. They can be intentional. And I talked about it before we got on about the chemical and biological warfare that's out there. And then there's also date rape drugs, and there's several of those that are out there. And Rohypnol is a big one. And then you're going to hear your chloral hydrates. Those are your knockout drops that they'll put in. There's other ones that they use for those. Once again, thank you so much for putting that in the chat for me, Lindsay. And your poison control center hotline number is 1-800-222-1222. It's probably one of the most easiest ones to remember. And so if you ever have a question about any kind of poisoning period, go ahead and call them, and they will help you until either A, someone with more knowledge gets there, or B, you get to an ER, or C, let's just say you're a parent. And hey, maybe you've already accessed the 911 system, but hey, while they're en route, maybe you want to call, or maybe somebody else wants to call. That's fine. Never, absolutely zero times should you hesitate to call the Poison Control Center. Okay. And access to information about all commonly used medications, chemicals, substances that might be poisonous, and things that are absolutely poisonous. They have all of those substances in their database, and they can even tell you about, okay, did they take this and this? Because that's really bad. Like that whole bleach plus ammonia. Those are bad, right? We don't do that. Let's talk about routes of absorption. And this is going to be real quick because you guys, this is easy, right? Toxins can enter the body in 4 main ways. You have your ingestion. Of course, obviously that's eating. Inhalation, you're breathing it in. Injection is obvious. And then absorption. Mark talked about fentanyl, and Christopher said something about improper BSI. There's some absorption there. And even improper BSI could actually be inhalation too. But effects and excretion rate are determined by the amount of toxin and the speed of metabolizing it. Now, I want you to understand that every time one of these poisons enters our body, it is in a unique way that it's going to be absorbed into the body. So if you inhale something, it's going into your lungs, it's going into your alveoli, and it's damaging your alveoli. When we damage our alveoli, we can't breathe, right? So that's one way. Injection, obviously, it goes into the bloodstream, it goes to the brain, it goes to the heart, it goes directly to the kidneys, and it kills certain things there, depending on what it is. Absorption takes a little bit longer, but that doesn't mean a whole hill of beans. Trust me. When I had years and years ago, I worked with a medic who did not take that first spray of nitro and put it into his gloved palm with a 4x4. And that's how you're supposed to load that dose. He didn't do it. He would do it in the air. And I would inhale that and I would get a headache. And so that's another way. Like even improperly managing the medications that we are in charge of is another way. So there's also combinations of toxins, and depending on what those are will determine the speed and the metabolism and even the excretion rate that happens in our bodies. And on top of it, and I'm just getting a little forward here, if you have somebody who's elderly, because Lindsay brought this up, elderly taking more medications because they just forgot, guess what? Their kidneys don't work as well as they used to. So their excretion rate is a lot less. Their metabolism rate is a lot lower. And so now you're going to have up to 3 doses in the body at one time. Alcohol is also a big one. You're right. Absolutely. So let's talk about poisoning by ingestion. And that's going to be a big one is alcohol. Absolutely. Think about medications around the home, household chemicals, things that are lying around, things that are easily gotten to or what have you. And you have to think about sometimes when you ingest things that can be caustic, there are things that are absorbed in the bloodstream before they can even produce a toxic effect. So before you even know you're sick, you've already absorbed all of it. And there's some indicators, they're super obvious, like you can have partially chewed leaves, missing berries, stained fingers, lips, tongue, empty pill bottles, things of that nature. You can have your patient complaining of a sudden onset of stomach cramps. They can have nausea, vomiting, diarrhea out of nowhere, right? There's a lot of different effects that could be immediate or they could be delayed. And so a lot of the absorption does occur in those small intestines rather than in the stomach. And it takes a while for these things to get to your small intestines. Okay, so how many of you have ever opened, just let me, ew, dishwasher pots, that's disgusting. How many of you in the chat have smelled activated charcoal? Just put a me in the comment section. I'm very interested to hear, because if you've never had activated charcoal, okay, you tried it. You are a lovely person. Lindsay, I would never try it. I smelled it and that was enough. They made you try it? Oh no, that's awful. It literally tastes exactly like it sounds. If you've ever grilled out and used charcoal briquettes, you can go lick one if you just want to taste what activated charcoal tastes like. I would assume that it is not real great. I don't know why y'all don't use it, Deborah, but we use it all the time. It is a binding agent. And there's only a couple of reasons why we wouldn't use this suspension. But it is a suspension. I want you to understand. So you're going to shake it up before you give it, and then it's going to bind to a poison inside of your stomach, and then it carries it out of the system. So what it literally does is it finds whatever the poison is, and it binds around it, pretty much making it like a globe, so to speak. And when it does that, it literally goes through the system, small intestines, large intestines, everything, and it stops the absorption process of other stuff. And so as it does that, it is a lot more effective and a heck of a lot more safer than our syrup of ipecac. And you'll see syrup of ipecac every now and then. And you won't see it on the truck. They have dismissed it from the truck, but you will hear someone talk about it. And when you hear about syrup of ipecac, it is to make people vomit. This is not. Will people vomit with it? It can absolutely happen, especially if they drink it too fast or what have you. And to be honest with you, sometimes when they are taking it, it just doesn't sit well in their stomach. So there's another reason why we will not use it on people that have ingested anything like gasoline, petrol, any fuel related stuff. And also, you don't want to give it to anyone who's had anything that's too caustic or too alkalinic, okay? And the reason for it is because if it comes back up through the esophagus, now we're going to have more of an airway problem, because if you have all of that coming up through the airway or through the esophagus, it's going to cause swelling, which is going to in turn put swelling onto the airway, okay? Let me catch up with you guys. Yeah, that's true, Lindsay. Nothing like it. Sometimes they will vomit. I've given it to several people in my time and they've never vomited. Yes. Okay. It is supposed to go through the GI tract and go all the way out. And absolutely, there are certain things that you have to have before you give this medication. First off, when you pull this out, you're going to pull it out. You're supposed to have a cup. You're supposed to have a straw. There's the times that I've given it, we didn't even get that far. They were just, here, give it to me. And they chugged it. But you want to have a bag mask ready to go. Seriously. Because if they've ingested this and they start to aspirate and after let's say they start vomiting and they aspirate, what do we have to do? We've got to prepare ourselves for airway management. So that's one. Obviously, we want an MSS bag because we want to watch out for if they do begin to vomit. So there are several things you have to have ready, whether EMT or advanced EMT at this point, okay? And that's a lot of people do now, Lindsay, is they just cut the tip off of the tube. But eons ago, when dinosaurs roamed the earth, we had to have a cup and a straw. And think about the fact that of some of these people, also, they may need an IV. My advanced carers now, I want you to think about an IV and think about the fact that you don't have to go super large bore, but a 20 gauge is where we really need to be, 20, 18 gauge, because just in case we need to give them volume resuscitation, especially if they're vomiting a lot, right? Yeah, I agree with you. Yeah, Deborah, great point. Yes, absolutely. Possible suction. You need to worry about your airway management, okay? Poisonings by inhalation. We have our home medications, of course, And we have, again, household chemical products, right? Think about your cleaning agents. Think about your cans of spray, people huffing, right? I'm saying a lot tonight. I apologize, you guys. Poison by inhalation can only occur if poison is present in the atmosphere. So if you get a call and there's 2 or 3 people that have gone down because of it, my very first thing is we're not going in there. We'll wait until somebody drags them out. And then the second one is, now what were they breathing in? And my first general idea is going towards carbon monoxide, right? But it can be a lot of other things too. We want to make sure that we call for our resources with our specialized protective equipment. And that's going to be our fire department, who are going to go in with their at least an SCBA on to get these people out. Okay, so there are, one of the big things about our inhaled toxins is they quickly reach your alveoli. Obviously, they quickly reach your alveoli. I feel like some of these things that they put in these slides are just absolutely ridiculous, because it's obvious. If I breathe in, I'm immediately getting air all the way down to my alveolar sacs. Absolutely. So our window of opportunity for treatment is absolutely limited. It is, there's rapid onset of signs and symptoms that occur during this window. And we're talking about this instantly gets into our circulation when we are inhaling things. That's why it doesn't take a whole lot for us to have poison by inhalation. So when you're dealing with this, obviously, in here, Lindsay even put it in the chat, scene safety is a big thing, okay? You have specialty personnel that you're going to have to call to help remove that toxin from the environment and at least get the patients out of there. Sometimes you have to decontaminate your patients as well, if you think about it. So also, when you get there to these scenes, think about where, hey, after we have gotten rid of all of the nasty in this area, we're going to need containers, bottles, labels, all of these, all this information. That way we can take this to the hospital, right? And obviously, if it's an inhaled toxin, I don't think we have to say it, but we have to say it, guys. Treat hypoxia immediately, okay? And I'm going to go ahead and tell you there is a special section in here talking about how you may have someone who tries to kill themselves in an enclosed garage, okay? And so I do want to talk about those. The sign of chemical suicide do include, and this is in your book, but a taped or sealed window. If you see trash bags that are taped over windows, that's your very first indication. If you see locked doors, sometimes you're going to have those posted warning signs, a suicide note, empty chemical containers, unusual odors. So if you suspect self-inflicting poisoning has taken place, of course, hazmat needs to be there to remove our patient, right? And then whatever information you have that you can give, you need to give to your medical providers when you get to your ER. And naturally, we're going to go ahead and get vascular access. And of course, we're going to get our pulse ox. Got to. Go ahead and call for an early paramedic backup at this point. I don't know, Mark. I've never heard of the powdered donut thing before, Lindsay. Can you put that in the chat for me? I'm interested. Okay, so poisoning by injection. Now, guys, poisoning by injection is a couple of different things here, right? Obviously, you have poison by injection, could be an overdose of simply they took too much insulin, okay? Another one, of course, where our minds usually go is drug abuse, and that's normally where we go is like heroin and things of that nature, right? Generally, injected poisons are impossible to dilute. So what we're going to think about, especially for our advanced EMTs, is we're going to go ahead and get an IV set up. Actually, our very first thing that we're going to do, monitor our airway. You got to think about the fact that a lot of these cause tissue destruction. And when that happens, it's going to just destroy our heart and our brain and other stuff. So we need to monitor our airway immediately, provide our high flow to go ahead and be alert for nausea and vomiting, all of those things, right? And we're going to get our IV set up, make sure that you have, and when I say airway, I don't mean just get out a bag valve mask. Deborah actually put this in the chat just a little bit ago about how you also want to get your suction ready. You want to get an OPA and NPA ready for these patients because you don't know what all's going to happen. And also keep in mind that your injected stuff can also be a bite or a sting. So don't dismiss that. If the stain fits inside the hole of the donut, you're far enough away. If the donut rolls downhill, you're uphill. If the powder from the donut blows upwind, then you're upwind from the stain. Oh, I love that, Lindsay. I'm going to use that from here on out. I appreciate that. Okay, poisoning by absorption. Okay, most serious absorption poisonings are from pesticides. You do have corrosive substances, old batteries, organophosphates, things like that, acids, alkalis, your petroleum products, your hydrocarbons. And that's going to have a huge systemic effect on you when it gets on your body and then it's absorbed. You can distinguish between contact burns and contact absorptions too. There are differences. So what are some of our signs and symptoms? You have your history of exposure. You have liquid or powder on the patient's skin, burns, itching, irritation, skin discoloration, and typical odors of substances. And you'll know what those are. Oil or dirty rags in a shop. Absolutely, Lindsay. Very good. So what do? We avoid contaminating others. So how do we do that? Our very first thing is we got to remove the substance from the patient. Remember, if it's a powder, we are going to wipe that off. We're going to get it off first. Then you pour water over it, okay? Do not do the opposite. If you see powder, you go ahead and put it under water. It can, some of those products do react to water. So do not do it. Flush after you have gotten all of it off of the patient. Cut off all the contaminated clothing. Irrigate the area with water. And as you can see here, they have different ones now for eyes itself, but this right here, I believe, is a nasal cannula upside down that they have rigged into a flush. Okay. And eons ago, that's what we had to have because number one, we didn't have it. We didn't have all of these fancy different eye stuff that you can get on the ambulance. But second, let's just be completely honest with each other here. A lot of our smaller mom and pop ambulance companies, private ambulance companies, just can't afford like a Morgan's lens. Okay. So you're gonna have to get effective with the tools that you have. Understanding and using toxidromes. There's a, let's see, Morgan lens. It is a, hold on, I'm putting in the chat. It is a lens that goes over the eye itself and it irrigates those eyes. So go look those up after the class is over, not now. So there are so many different substances that you can abuse. It's ridiculous, right? So we have toxidromes, which are syndrome-like symptoms of poisonous agents. So all narcotics, doesn't matter if it's natural or synthetic, they're going to work in that similar manner. Does that make sense? I hope that there's some understanding there. All of our opioids work similarly. All of our inhaled CO2 poisonings, they're all the same. It doesn't matter where you're getting it from. So our major toxidromes are going to be stimulants, narcotics, sympathomimetics, sedatives and hypnotics, cholinergics, and anticholinergics. Yes, Jared, thank you. That is exactly what that looks like. And so one of the things that we do is we put these guys under this umbrella, so to speak. So stimulants, what do stimulants do? They stimulate the body to do things. Some stimulate the body to get up and go clean the house, and other stimulants are we can get up and go clean the house and we take apart the washing machine and dryer and put them back together after we've cleaned them. And you guys know where I'm going with that one, right? Like the methamphetamines do that. But stimulants across the board, doesn't matter if it's in your Dr. Pepper or if it's in a Vyvanse pill, it all does the same thing. It makes your heart race, it makes your respiratory rate go up, it makes your blood pressure go up, it makes you go. You get jittery, you can get spastic, you can, like, there's a lot of different things that happen, right? So some of those can be naturally occurring, some of them might not be, but you get the drift, okay? Oh, let me come back over here and check out the table 23-1 and 23-2. Check those out for sure, okay? Okay, so overview of substance abuse. There's an area of medicine is challenging, uncertainty of prevalence of problems and evolution of substances. Substance abuse is broadly defined as the self-administration of illicit or licit substances in a manner not in accordance with approved medical or social practices. So let's break that down. Social practices. So is it okay to go have a couple of drinks after work with your meal? Yeah, that's a social practice. That's fine. Is it a social practice to go home and down an entire fifth of vodka by yourself? That's not a normal social practice. And that can be substance abuse right there. So that's where we're getting at. That's what the social practice means. And so there's a whole bunch of different cultural variations to what is considered substance abuse. You go to Italy, they have wine with almost every meal. I'm not saying they do with breakfast, but they definitely do with lunch. They definitely do with dinner. They even have what I like to call wine 30 with their cheese and their wine, and it's wonderful. And they have conversation, and then they have wine with dinner, and it's great. And booze and chocolates. Exactly. They have all of those things. And that is wonderful for that culture. But here, that's a little different. We don't do that in America. And that's okay. But society's definition may have little relation to the potential harm of a substance. Okay, tobacco is restricted to 21 and younger now. But is it now? I take that back. It is not socially acceptable anymore. There's a lot of places that you cannot go and smoke a cigarette any longer. But it happens. Marijuana, there are certain states where it is okay for people to smoke marijuana. They get treatments for it. From in the state of Mississippi, you can get medical marijuana after you go through and talk to a doctor, and then you get a card, and then you go find the dispensary, and then you do the thing. You go to Colorado, you can go wherever and get it. You don't have to have a card. So it depends on the definition of where you actually are. Now, important substance abuse terms. Okay. And I can read through these. Oh, same with California. Drug abuse, obviously, if it causes harm because of the effects of the drug user's behavior, right? Habituation, that's dependence on this drug. Physical dependence is a physiological state of dependence on the drug. Psychological is the emotional state of needing that drug. Tolerance, of course, you get an increasing larger dose as of this drug to achieve the same effect. That's why they say you'll never get as high as you did the first time you took crystal meth, cocaine, and heroin. Okay. And pain medication abuse is another one. Withdrawal syndrome. Okay. Withdrawal syndrome is bad. Now, this one can cause an altered CNS activity. And because of it, it can cause some major problems down the road, depending on how much they've had. And seizures is one of them. Thank you, Lindsay. We were going to get into that in a minute, but that's exactly what it is. Okay, drug addiction is a chronic disorder characterized by the compulsive use of a substance resulting in physical, psychological, or social harm to the user who continues to use the substance despite the harm. And of course, an antagonist is the counteraction of what you've taken. Potentiation is just an enhancement of the drug from another one. And synergism, this is the action of two substances, such as drugs, in which the total effect is greater than the sum of the independent effect. And so that's where it's 2 + 2 = 5. And drug abuse occurs in all age groups and social levels. So adolescents are definitely particularly prone to the experimentation. Remember we talked about earlier in having kids are the ones that have the worst. No, we didn't talk about this. Was a class I did a while back. I'm getting y'all confused. But moving like way ahead of time into trauma, children are the ones that get hurt the most. Why? Because they don't know any better. Okay? They don't have fear. Why don't they have fear? Because they haven't fallen before. They don't really get it. And so that's why adolescents are very prone to experimentation because they don't know what they don't know and they want to know. Oh no, Deborah, that's terrible. Absolutely. And it's just withdrawal symptoms can be horrible for the patient themselves. So I'm sorry you had to go through that. And it hurts our hearts when we see that. Okay, so scene safety, obviously, we determine our NOI, MOI, number of patients. Do I need additional resources? Is there spinal immobilization necessary? And of course, we're going to get our PPE out. And remember, everything can be dangerous. We're going to look for clues as we walk up. Oh, is there a paint can there? Is there something spilled? Is there alcoholic beverages? Are there syringes? Is there a nasty odor? What is going on? Our primary survey is going to begin with our general impression. And I'm going to go ahead and tell you exactly what it says here. Do not be fooled into thinking that a conscious, alert, and oriented patient is in stable condition. Why? We already talked about it. Okay. Other than inhaled stuff, inhaled poisons take effect very quickly. But didn't we talk about earlier how absorption takes a lot longer? So your patient may have this white dust, nasty stuff all over them. You have no idea what it is, but you're getting it off of them, and then you're going to wash the contaminants away. But it could be hours later that they take a turn for the worse. Or it could be minutes after you've gotten there. So that's another one. Alcohol abuses are a huge one, Lindsay. You keep bringing alcohol up, and that is a huge one. You have people that are, and words escape me, Lindsay, go ahead and tell me what it is, because I know you know what it is. The ones that can drink a case of beer a day, and they can walk into Walmart like nothing happened. But anyway, those people are some of the worst, because if they miss a day of drinking a case of beer, they go through DTs. And so those are the ones that are like super dangerous. Anyway, I'm getting off on a tangent over here. So patients, they may have that lethal amount inside their system and you just don't see it yet. So be careful, be wary. Understand you go back through our ABCs over and over again. Okay, we got to. What is that word, y'all? Oh my gosh, why can I not think of that word? And it's because their body has built up such a tolerance. But anyway, it's going to come to me at 2 a.m. tonight. But these are alcoholics that they go to work on a 6-pack of beer, and they can work all day and nobody even knows they're drinking. Okay. But definitely do not hesitate to give oxygen therapy to these patients, especially if it's somebody who's inhaled something, right? We really want to give them oxygen. So we're going to go for the patient circulatory status. You're going to assess the pulse, skin condition, check for bleeding, of course, and any obvious alterations to our ABCDs. Okay, so you think about stimulant exposure. We already talked about it before, but think about its restless agitation, incessant talking. They won't shut up, and they bounce from one subject to the other. Insomnia, anorexia, they're going to have the dilated pupils and tachycardia, tachypnea, hypertension. Sometimes they might even have hypotension, paranoia, seizures, even cardiac arrest. Depressant exposure is generally the opposite, with respiratory depression, bradycardia, drowsiness, and even coma. And so if there's any of those alterations, you want to check into making sure they're okay. Okay. Consider deconning your patient if necessary before transport, depending on what that poison is. And I can go ahead and tell you that you're not going to get that patient on a helicopter without them being decontaminated fully. Not intolerance, Jacqueline. I appreciate it, but that's not it. Okay. History taking. OPQRST, obviously. That's our biggest one. If your patient is responsive, go ahead and get that sample history and the OPQRST out of the way. But if not, if they're unresponsive, of course, we're going to check every other way possible, including talking to our family members, talking to the friends, talking to whoever's around, right? Okay, so history taking, again, what is the agent? That's the most important part, right? If this is a truck driver and maybe the contaminants of whatever he had has spilled, you get their sheet. I'm going to get that in a minute. Somebody put it in the chat. Y'all know what it is. I don't know what the SDS is. That might be it. MSDS. That's it. Yes, MSDS. I knew you were right. You want to get that from them, okay? When was the poison injected, absorbed, inhaled, all of that? When did this happen? How much did you take? What else did you take? Over how long did this happen? Have you done anything else? Okay, safety data sheets. Yeah, material safety data sheets at that. Thanks, guys. Y'all are awesome. Has the patient vomited? Have they aspirated? Have you listened to their chest? Okay. How much does our patient weigh? Yes, that is important. Why? Because we may have to turn around and give them a fluid based off of their weight. It could be, and here's the deal. 2 Tylenol is for a normal walking around as per what's normal on a BMI scale, okay? I live in Mississippi, and I think now we're no longer the number one, how do I put this nicely, largest state in America. And by large, by weight, okay? So you have people that walk around that can take 4 to 6 Tylenol at one time, and they have not overdosed. They're taking the correct dosage for their weight, if that makes sense. So we want to know how much they weigh for that particular reason too. And why was the substance taken? Did you do it because you wanted to commit suicide? Things of that nature. Okay, so secondary assessment, we're going to focus in on that area involved with the poisoning. So if they inhaled it, obviously lungs. If they ingested it, obviously we're looking at the GI tract. You get where we're going here, right? So perform your complete set of baseline vital signs, because we want to see, is it trending up? Is it trending down? What do we need to do here? And look for the alterations in your LOC, pulse, respirations, blood pressure, and skin. Reassess your ABCs, ABCDEs actually, and evaluate your interventions, and repeat your assessment of vitals every 15 for a stable and every 5 for a patient who has consumed a harmful or lethal. It is a chronic drinker, but I cannot think of the word for it. When I go to break, I'm going to find it. Thank y'all for trying. Functional alcoholic. My gosh, Joshua, where have you been? Thanks for paying attention to class, sir. Golly. I hope I just made everybody laugh at home. Okay, so interventions, but yes, functional alcoholics are really, they're the ones that we have to worry about the most, because if they have a lot, then that's great. Christopher is in the chat, apparently. Hello, Chris. So interventions, of course, we're still going to support our ABCs. Remember, we're worried about our airway, especially with anybody that's overdosed, because it doesn't matter if it's a stimulant, okay, guys, but especially if it's anything else, we really got to worry about our airway. We got to worry about our respiratory rate, depth and quality, and what are our pulse and everything else, right? Okay, dilute airborne exposures with oxygen. Okay, remove contact exposures with water, and consider activated charcoal for our ingested poisons. And remember, these guys could vomit at any time, so we got to continuously worry about that airway, right? So what are some of those things that we need to have next to us? We need to have, not that Chris, the other Chris, but hi. Okay, think about, now I've lost my train of thought, but contact med control or your poison center control. That's that 1-800-222-122 to get to discuss treatment options and where we need to go, what we need to do. Okay, so once we've done our primary survey, we need to worry about what other necessary interventions there might be. Do we need to call for a paramedic backup? Probably. We don't want to report as much information as we can to the poison control or at the hospital, naturally. We already talked about MSDS. If that's immediately available, go ahead and get it. Take it to the hospital. If it's not, ask that company to send it. Email, fax it. I don't care. I don't know anybody that has a fax machine anymore, but email. That's probably a good one. So let's talk about our emergency medical care at this point. Obviously, we got to worry about our safety. I want to be safe when I go home at night. I'm going home at the end of my shift, right? Now, so are the rest of y'all, okay? Follow standard precautions, perform external decon, and make sure that you're good to go. Remove tablet fragments from the patient's mouth and wash or brush the poison from the patient's skin. Remember, we're going to brush first, and then we're going to wash with copious amounts of water, all right? I don't like how this slide is done, so we need to redo that. Assess and maintain your ABCs, provide oxygen. We've already spoken about that. Assist ventilations, go ahead and get those ready. We're gonna have to have our BVM. We're gonna have to have at least a non-rebreather, but a BVM is gonna be on the backup, right? Get an OPA ready. Go ahead and get them as you're putting a non-rebreather on your patient. Go ahead and see how much you might need by measuring your patient with an OPA. Just try to, hey, I've got it. I know what it is. It's right here, just in case things go bad in suction. And then, of course, we're going to treat for shock if necessary, because if they demonstrate any signs and symptoms of shock, then we're going to go ahead and do what we got to do, right? And for my advanced EMTs, we're going to start those IVs and we're going to resuscitate as necessary by using our normal saline, right? Okay, and if approved by medical control, we're going to give our activated charcoal. Now, we talked about this earlier, but let's go over it again. You don't use activated charcoal. It is contraindicated, not indicated, contraindicated for people who have ingested acid, alkali, or a petroleum-based product like a hydrocarbon, who have a decreased level of consciousness and cannot protect their airway, and those who are unable to swallow. We're not doing that. We're not going to give ourselves more problems, right? One of the side effects of the activated charcoal, a couple of y'all actually said this already, that it goes through the body, and yes, it gives you black stool. You may have the vomiting. That's the biggest one. So when you have vomiting, guess what? The dose does have to still be repeated. Sorry, you're the one that took the medication, or you're the one that did something bad. I'm sorry. I can't help this. I have to help you, and this is how I help you. And then there's nausea, but think about your possible airway problems, guys. So if we have nausea, vomiting, we're going to worry about aspiration. So go ahead and have that stuff ready on the side. Suction unit, bag, valve mask, whatever you may need. Okay, alcohol, y'all. Obviously the most widely abused drug in the United States. Why? Because it's legal. It's legal everywhere. You got to be 21 years of age to drink it legally. Doesn't mean you got to be 21 years of age to get it, right? So 15 million people in the US suffer from alcoholism. That's more than 10% of our population suffers from alcoholism. And by definition, it's a state of physical and psychological addiction. It is the fourth leading cause of death in the US. Guys, that's really bad. So people with alcoholism, they tend to have chronic malnutrition, fall asleep frequently, and they have an increased likelihood of trauma because of all of the problems that come with drinking alcohol, as it being a CNS depressant. It decreases your activity and excitement. It's going to induce sleep, and it dulls our senses of awareness, slow reflexes, and reduces reaction time, and causes aggressive and inappropriate behavior, and even lack of coordination. So, yes, sir.
So also on your alcoholism, make sure that when you do that, that you will also notice that if you go to somebody's room or anything like that, you will notice that they will also have the predominancy of being on a CPAP machine. So when they go to sleep, or they'll sleep at an angle and all that, not because they have fluid or anything, it's just because that they have a respiratory compromise, and it's just a drive issue. It's not like it's being held by medical reasons, but medically they have more trouble breathing when they sleep due to alcoholism. That was it.
Thanks. I actually have not, I never knew that one. One of the things about alcohol being this powerful CNS depressant, I want to go and talk about the aggressive and inappropriate behavior real quick. Inappropriate behavior can be anything from laughing really loudly and being very obnoxious to trying to take off your clothes. Okay. Inappropriate behavior can go from all of it. And obviously, we understand aggression, and we also understand that we are professionals. We are not under a CNS depressant. So we need to understand how to handle ourselves and those patients who do become aggressive. Once again, we never want to put ourselves in the line of getting harmed. We want to make sure that we get home at the end of the shift. But you need to understand that you're going to have those issues sometimes with this aggressive behavior. Now, one of the several of the medical problems associated with alcoholism, we talked about it before, is that trauma. So look for signs and symptoms of head trauma. Okay. Look for signs and symptoms of trauma anywhere. Old bruises, new bruises, bleeding, things of that nature. Also, toxic reactions. What if they're taking something else? What if they're already taking a hydrocodone for something, and then they drink excessive amounts over it? Okay, what if this is somebody who they normally drink all the time, but they fell down and they broke their leg because they were drunk? They go to the ER, they get their medication, they come back home, and they still continue to drink even though they're taking the medication. So that's another one we have to worry about. Another one is uncontrolled diabetes. You will see that. Severe alcohol ingestion may cause hypoglycemia. And when you see that, You want to check the sugar of every single patient that you either, hey, if you know they're drinking alcohol, fine. But never ever just let it go that they're just drunk. Always check for a sugar to provide evidence that they are not hypoglycemic. Also, New Orleans, Hattiesburg, I feel increased also. Nice because people probably more. That is very true. You really have to watch your surroundings and where you are. Very good. You can have death from respiratory depression, aspiration, vomit that comes up in the middle of the night, or what have you. I would think that if you were on a CPAP machine and you vomited while you had one in, that would be really bad. Physical dependence and withdrawal. We talk about DTs. You guys, DTs are really bad. I mean, if you have somebody that you think is in DTs, delirium tremens, then you're going to go ahead and call for a paramedic backup because they have a lot more things going on than what you can handle. A minor withdrawal is just, it's restless. There's maybe some sleeping problem. Maybe they're a little agitated, stuff like that. But major ones, you're going to have, and they call it tremens, but they do have tremors. Tremors. I want you to understand that there is a difference. They're restless, they're weak, fever, they're diaphoretic, they have hallucinations, they're confused, they become severely hypotensive. They can have, I don't recall itching, but that doesn't sound like that's not in the realm of possibilities. Seizures is a big one. Coma, possible death at some point. So when you have someone that's considered an alcoholic and has been for a number of years, think about when you take them away from it, or they're trying to quit drinking for whatever reason, they're not doing it with the help of someone, then get ready for DTs. And it's not pretty, but definitely call for your paramedic backup at that point. Think about hepatitis and cirrhosis, guys. Liver damage is the most common. 90% of our heavy drinkers have some level of hepatitis, and you will see this increased. You can look on their face and tell. They will have, especially later on as the hepatitis gets worse or cirrhosis gets worse, you'll have jaundice in the sclera of the eye. And so you'll walk in and you'll be able to see immediately. Consider internal bleeding if the patient appears to be in shock. That's another one. Um, Go ahead and hold on. Let me read these notes real quick over here on the side because it's talking about something different than what's on the slide. Okay, withdrawal symptoms include our seizures. We did talk about that, and that's usually within the first 12 to 48 hours. And essentially, our paramedic will have to go on the scene. They have benzos that they can give this patient for seizure control, and they are going to help with the treatment of this patient, especially when we're talking about hypotension and everything else. If the patient does exhibit signs of DTs, we're going to keep them as calm as possible. Now, remember, they may be having hallucinations, and some of these can be very terrifying. And you can have somebody be extremely combative. So you just do your best to keep them calm. Remember, we're going to lower our voices. We're going to speak slower. We want to talk to them in a way that we keep the peace. Of course, oxygenation, manage our hypotension with an IV, and then maintain that open dialogue. Ask them questions and reassess all the time. Okay. Guys, it's 6:58. Let's go ahead and take a small break. We're halfway through. So let me put my timer on. And we will come back in 10 minutes starting now. Okay, guys, Chris is here tonight. He wants to show us something. He has control of the board, and I'm going to let him do what he's got to do.
All right, folks. I know Patricia was going over the SDS, and oh, FYI, if my voice goes robotic, I've had to go back to the old age of how to get internet out here for right now. SDSs are material safety data sheets. For the ones that don't know, just want to go over that. For the ones that have seen them before, you can just listen to me talk. But what I wanted to show you guys is some of the things that stand out on SDSs and what's really important to us when she was talking about when somebody hands you one or they give it to you or you can send it to the facility. So here is an SDS that we have. I have gone through and highlighted some things. This was for another project that we have here on the facility. But so this is the chemical name that's normally in the top left-hand corner. Right here, this is what it's used for. So some of the things that kind of stand out are all of these placards right here. So we know it's flammable. We know it'll kill you. We know it's a respiratory problem. Obviously, if it gets on your hands, and I guess they're guessing too. No, I'm just kidding. It has a particular name. So when you look at these hazard statements, these are some of the things that stand out to you. If you'll look, you notice how I've changed them colors. One is because yellow is what we're going to be more worried about here on the facility. But these are some of the things that they will tell you. These are hazard statements that they break down. If you're reading over it, obviously that some of the things that you're seeing may be what you visually see on your patient. When you look at this section for protection, personal protection, that doesn't matter to us as an EMS. We don't really care what goes on right here in this section because we just it doesn't, I'll just say it doesn't matter, but it matters to us out here because we need to know how to handle it. So the company that makes it turns around and says, okay, so here's the standards for handling this product to keep you safe. So it doesn't just call for regular rubber gloves. It has to be made out of a certain type of rubber gloves. So what we want to look for is right down in here, first aid measures. This obviously we're not going to know what chemicals what. There's thousands, millions of them out there, but this right here tells us what we need to do if there is contact in the skin, the eyes, swallowed. So prime example, wash off immediately with plenty of water for at least 15 minutes. Use a mild soap if it's available. Wash clothing before reuse. 90% of the time it's easier just going to throw them away. Thoroughly clean shoes before reuse and get medical attention. So that's telling us we can use a soap. Now, when they say a mild soap, Dawn is really good. A lot of your facilities will have Dawn or a hand cleaner soap. Most of the time, your hand cleaner is going to have some grit in there, and what that grit is doing is just trying to take it off from the skin. So all of your SDSs will look like this. They will have these examples. They will tell you what's going on. But I wanted y'all to see that 99% of your SDSs, as long as it comes from the US, is required to have this section right here for first aid measures. It'll go down and tell you how to do firefighting and what happens if there's accidental releases and stuff. But we have every company that deals, even trucks like 18 wheelers go up and down the road, you will see some of these placards on the sides. They also are required by DOT, sorry, to have copies of the SDS on hand. If for some odd reason the driver is incapacitated, just know those SDSs are somewhere in that truck that has to be obtained. So they're most likely within their reach pretty close. But when they hand it to you, you're only looking for the first aid measures, not anything other than that. Normally, these are kept in like a red, bright notebook that says SDS, and they change them out from the facilities they go to just because they have to. We actually have some out here now. This is probably one of the worst ones we have because it's like it even gets down and affects your fertility of the unborn child. So we do have some that is has a water toxicity to where if we were to spill it in the ocean, you're going to have potential high marine death. So we use that to clean our water that's in the oil that we have to send to be cleaned, and it's basically put back in the ocean. Every rig across the world has hazard materials on there. A lot of your trucks going up and down the road has those. The most dangerous truck that we see on the roads these days are your Walmart trucks because it has to be over 1,000 pounds of a particular product for them to be required to mark their truck. If they're hauling 900 pounds of batteries, 900 pounds of bleach, they're not required to mark those trucks. So any truck that you see driving down the road that has placards like this have over 1,000 pounds of that particular product. So I just wanted to show y'all, we deal with these on the daily. I guarantee you there's probably 500 SDS sheets out here. We even have to have them for Windex that has ammonia in it just because there's hazards down here that talks about if swallowed such and such. We have all of ours are now online, but our main big, most deadly ones like this one, we have them printed and this is the one that we will print and hang inside the clinic so we know what to do if that particular chemical gets on them. Now a lot of this right here is not going to correlate with what that particular product is called. It's just like when we were doing pharmacology. This is what the name is given by the company that makes it. CORR 1161 SP, or 1161 2SP. That is the chemical makeup of this particular product. So when you look at it, be like, yes, we know this is the sheet that he has this material on him. Just wanted to y'all to show that I knew I had this sheet and I thought it was a good idea when she was going over SDS, and I just wanted to show y'all. So you can find those. There's some very good resources out that you can, like you used to be able to get a little orange book every 2 years, but they've quit doing those books. A lot of it now, you carry the power of the world in your hand. So that is part of the ones that you can start using now, is that part. But that's it. Y'all have any questions about SDS on what I was showing y'all? Okay, Patricia, you can take it from me. I think Patricia left.
I was busy sipping some Dr. Pepper, sir.
Oh,
That's right. Let me find my share button and get back to it.
talk about the big red button.
Oh, I got it now.
I told you.
No, that's not what I meant. Hold on. No, this is your fault, Chris.
I'm sure.
At least okay. Yeah, it is. It's my fault. I don't think this is going to go back to, yeah, hold on. Okay.
You were on slide 38.
41, but thank you.
My bad, I was off.
It's okay. All right, let's change this view. It is always Chris's fault. See, if that's test question. Y'all will get it right now. Okay. Okay, so let's get back to narcotics, opiates, and opioids. Okay, so narcotics all the way across. Remember, we talked about how we have toxidromes, right? So this is a toxidrome. It's a drug that produces sleep and altered mentation, right? Your opiate is natural, whereas your opioid is synthetic. And that's the only difference between the two. And you guys can look up these examples, but guess what? They're still going to do the exact same thing. And they are the most common causes of overdose deaths reported to poison centers across America. And these are going to all cause the exact same stuff. So the opioids bind with receptor sites in the brain and in some other tissues, like in your GI tract, in your nasal mucosa, lungs, things like that. They're absorbed very quickly there. And the reason for it is because of what that lining is actually made from. It is the chemical makeup, the cellular makeup is why that absorbs so quickly there, okay? When heroin passes through your liver, it's going to continue to exert narcotic effects that may outlast the effects of your Narcan or say heroin is abused for that euphoric effect that it sends out. Fentanyl is super potent. We've probably run a lot of calls on those recently, even or more so recently than yesteryear. And you're not just dealing with patients, you're dealing with other people that are caring for the patient that are also getting fentanyl overdoses. So we need to watch out for that. The major effects of your CNS binding with these receptor sites in the brain and other tissues, what happens here is when it does get absorbed, it takes a while for not necessarily the absorption to take place, but it takes a while to unbind, if you will, from those receptor sites. So that's why it takes so long. In 2023, there were 1,120, no, my God, 112,000 overdoses, the highest number ever. That is insanity, you guys. Insanity. It's just crazy. Morphine, it's an analgesic. You see it it's on the truck, okay? And it's a potent vasodilator, but guess what it does? When you give it to our young adults, it's metabolized in 2 to 3 hours. Adults do take a little bit longer, but what does that do? It gives like this dreamlike state. Most overdoses involve Opioids, heroin, and prescription painkillers. Absolutely. Essentially, what happens is after that injection happens, they're going to appear to pass out. And they may actually be lucid, but they will pass out immediately afterwards. And they go into this dreamlike state. And people love we talk about us understanding how to handle stress. And there are people that get to this point and they just cannot handle it anymore. And they want that euphoria to take away the things that they've had to go through. Some of our presentations, and I want you to look at some of these. Euphoria is one, but okay, hypotension, respiratory depression, pinpoint pupils, vomiting, coma, and seizures. The vomiting, when vomiting does occur, guys, what is our number one thing that we have to be careful? We have to really watch. Go ahead and put it in the chat. I already know y'all know, but I want to know that you know. Hypotension, respiratory depression. What are some, Joshua? No. Dehydration, yeah, but no. Let's go to the most obvious answer. Jared, you're right. But the fact of the matter is that probably if you have somebody that's taking narcotics anyway, yes, Jared, that's right. Exactly. Thank you, Joshua. It is airway. We want to worry about our airway compromise. But where was I going with this? I'm so sorry. Watch My Shoes has got me off.
Talk about when they vomit and they're overdosed.
Yes, when we're worrying about our airway, worrying about whether or not we're aspirating, you also have to worry about respiratory depression on top of it. And yes, asphyxiation is definitely one of them. When we already have respiratory depression, now we're going to put vomit inside of we will asphyxiate, and it's going to be a slow, painful death. It's going to be really bad. So we have to really worry about immediately if you have this patient, they're unconscious, and we're not worried about, hey, they fell on their head or something. Go ahead and put them in that recovery position and let some of the gravity take its course and get that vomit out, but get ready with our suction, get ready with our OPA, get ready with our bag valve mask, get ready for a paramedic to come help because you're going to need this at this point, okay? Narcan does reverse the effects of the opiates, and it's naloxone or Narcan. It is just an antidote. And how does it reverse the effects? It literally goes to those receptor sites that opioids and your narcotics like this have binded to, and it says, hey, yo, you got to go. No, it's my turn. And so it effectively unbinds that to them. So what are we going to do? We're going to go ahead and get an IV line started. We're going to go ahead, and if you can't get an IV line started, we're going to give it IM. There's intranasal. That's huge now, okay? Your acute narcotic reversal may lead to vomiting, naturally. Also, it could make somebody really angry. So be ready for that too. And for two reasons. Number one, they're going to wake up and they're going to look at you and they're not going to know who you are or why you're standing over them or why it's so bright in the back of the ambulance. Number two, once they wake up, sometimes they're going to remember. Do not do what Christopher said in the chat. Number two, they're going to realize, hey, you just made me spend $100 on a high. I was having a really good time and you just took it away from me. And now I'm going to take it out of your rear. So you have two different things that could be happening right then. They could be fighting you because they don't know who you are. They could be fighting you because they're angry at you. So what are our doses? Our doses of Narcan are going to be 0.4 to 2 milligrams. All right. Some EMS systems do allow our advanced EMTs to administer it in the intranasal route. And so it's atomized through the nares into the nasal mucosa. Remember, we talked about how the GI tract, the nasal mucosa are the ones that are readily have that passage through very quick metabolism absorption rate, right? So you may have acute narcotic reversal, may lead to vomiting and that aspiration. So once again, we got to worry about that. Make sure that your patient, and I will say this, when you're giving Narcan, you want to do it to reverse what's going on. So what's going on? First and foremost, we have to worry about our respiratory depression. So is our patient so respiratory compromised they have abdominal respirations and apnea? If that's the case, we're going to bag them, right? That's our first go-to. Get an OPA, MPA established and go from there. Of course, we're going to bag valve mask that patient too. But if the patient does not respond to Narcan, It's possible that they have a mixed bag dosage or overdose rather. And so what does that mean? It's like a Skittles party in the 2000s. If you don't know what a Skittles party is, good. But if you don't, I'm going to educate you. The Skittles party was everybody brought pills from home and they threw them in a punch bowl. And whoever was there at the party, they would just take random drugs and they would just take them. And so you never knew what that person was getting. And so that was really bad. That's really hard to figure out what to throw at them to get them to wake up. It could be that your patient has a head injury on top of it. So there's a whole bunch of different scenarios that you have to worry about whenever you're dealing with patients like this. So we're just going to monitor our patient very closely. It's been a minute, Lindsay. I'm telling my age. Stimulants, completely opposite of what we've been talking about. Several different ways you can get that in your body. Clinical presentation, excitement and delirium, tachycardia, hyper, also hypotension, but with a fast pulse. You're going to have dilated pupils, tremors, and even seizures, depending on how much it is. So let's talk about our cocaine. That is a natural occurring alkaloid that is extracted from a plant in South America. And once it's processed into your cocaine, the active ingredient is the leaves in its 100% purest form, and its toxic potential is increased naturally. So there's a whole bunch of different names for it. I'm not going to go through all of those, but cocaine is a local anesthetic and CNS stimulant. Hey, side note, did you know that cocaine used to be used in several different things? It was used for women who had quote unquote hysteria in the 1800s, and it was a tonic that they were given. There were some other things they gave women for hysteria, and we are not going to talk about that. And if you were curious, you may look those up on Google yourself. But they gave women like some crazy stuff. Exactly. It was in Coca-Cola. I'm not sure if it was before it was deemed Coca-Cola or not. I really can't remember the history there, but that is true. That's how Coke got its name. There's just a whole bunch of different places that cocaine has been. It is quickly absorbed across all your mucosal membranes. All of them. All of them. So you may not see that someone is snorting cocaine. They may be putting it in another mucosal layered orifice besides their nose or swallowing it. It could be snorted, it could be injected, of course, can be applied topically even, which is very interesting also. And it may be mixed with some other ingredients that are good, bad, indifferent. Baking soda, some is water, others are other types of like crystal methamphetamines, things of that nature. Yes, Chris. Yes, Mark. That's the face they made too. Y'all are disgusting. They will make a paste-like slurry even. Actually, I'm the one that brought it up, so my apologies. It is. It's found in certain places when they try to hide it from the PD. So there's a whole bunch of different ways that they can put it in different places, and it do really have really bad effects. When the cocaine does wear off, they have a crash. They may be depressed, clinically depressed even, irritability. They may have sleeplessness, exhaustion, and depending on the amount of length that they have taken it, this patient may experience a cascade of adverse effects. And that's called the cocaine washout syndrome. And it's a big thing. The syndrome presents as a hypoactive state related to a lack of the synaptic neurotransmitters that go off. So that's something else that you will see. Amphetamines. Now, there are some legitimate clinical applications. There's derivatives of that. Of course, we have methamphetamine, and there are some other ones. You have MDMA, ecstasy, a whole bunch of them that are illegal, right? But then there's some legitimate ones. And what Lindsay said, Adderall is one. Vyvanse, I take Vyvanse. I'll never forget, I worked for a local community college here in the great state of Mississippi, and I had to take a drug test along with all of my students. And the assistant dean was waiting outside of my office one day, weeks after I had taken this drug test, maybe not even that long, but a while afterwards. And I'm thinking, oh my gosh, did I hurt somebody's feelings? Did I fail the wrong? What did I do? The assistant dean is waiting outside my door to my office. Like, where's the email? Like, why was there not a phone call? Was what I was getting at. And she said she came into my office. We sat down for a second. She closed my door. I started shaking. I'm not going to lie. And she says, so your drug test came back and you're positive for methamphetamines, or you're positive for amphetamines. And I said, oh, I take Vyvanse. Still shaking, handing her my prescription. But it does. It has other legal or legitimate legal clinical applications. Nasal decongestion. They're diet pills. There's drugs for narcolepsy. And of course, for our ADHDers like me. But you have to also remember that because of people that do have ADHD, they may be those people that they'll take more than one or two, and they can have an overdose of stimulants as well. So synthetic cathinones, and that's okay. That's okay. Have become a public health problem over here. You have these things are called like blaze, bath salts, things of that nature. I know you guys have heard of bath salts. So Sudafed's no longer really sold. I think you have to go up to the drug counter itself and get it. It may not even be there anymore. I'm not even entirely sure. It has been so long since I've seen Sudafed. But they make things out of this besides just popping the pills to get high and to have hallucinations. Sometimes they do have paranoia along with it. So you're going to have this wide-eyed, thin as a rail appearance. They do not eat. Which a lot of people that do take stimulants are very skinny, unless you have somebody who actually has ADHD and they do eat, because the drug works on us differently than it does someone who does not have ADHD. It gets people that don't have ADHD high, whereas us, it makes us do work and actually do it. So complications associated with cocaine, you're going to have heart attacks. That's a big one. You can have, and it's lethal arrhythmias that you're going to see when these happen. Seizures, stroke, apnea, they're going to have hyperthermia. And so when you see this, worry about these things happening. Always be in the back of your mind. Okay, I need to do a strip on this person and see where their EKG is. I need to make sure of going through and getting our basic vital signs as we go. And be aware, you can have a lot of different other complications, can include incredible strength. That's a big one. They have more strength than they know. And if they are paranoid and having hallucinations at the same time, they can really hurt you. So be careful of that too. Oh, thanks, Jill. I just saw that comment. Okay, so some of the treatments for stimulants: maintain maximum oxygen saturation levels, prevent seizures with adequate sedation. You're going to call for your paramedic backup at this point. Monitor serial vital signs. Guys, every 5 minutes with these guys, okay? Go ahead and consider getting your paramedic backup and establish an IV to manage our hypotension. Apply your pulse ox and go ahead and get ready for them to use benzodiazepines if necessary to help with anxiety and seizures. That's going to be your paramedics, of course, but you need to be aware that's what they're going to use. And if you have a patient that is hyperthermic, you can help reduce that by, of course, getting them in a cooler environment. Don't forget about misting the patient potentially if you have something to do that with. Ice packs. There's a whole bunch of different ways that we can do that, right? Okay, marijuana and cannabis compounds, usually smoked, effects are pretty quick. They do result in bronchodilation and slight tachycardia. Some of the other ones, of course, euphoria, drowsiness, diminished motor coordination and bloodshot eyes, and management focuses on pretty much just supportive care. They usually, when you smoke it, it takes minutes, but of course we have ingestion. There's a whole bunch of different things. Which patient? If you're talking about the patient prior to this one, the stimulant patient, absolutely, I would give a fluid bolus if they were hypotensive, 100%. If they're overheated, then no, I'm not going to give them a fluid bolus to do that, because if they are hypertensive and you give them a fluid bolus just because they're overheated, that's not what it's for. Good question. Okay, management focuses on supportive care. So what that's going to be is, of course, in a position of comfort, make sure you take their blood pressure, all of the different things, right? But now let's go into some other stuff that it might be. What if it's spice? Okay, that's a mixture of a couple of different things, and that's a psychoactive drug. And that's going to be your cannabinoids, but it's going to have some other stuff in it, right? And you may see that in vapes. You may see it in just regular smoking. They may end up putting it in something and eating it. So there's a whole bunch of different things, but you're still going to be supportive care. There can be benzos given in case of seizures, but that's once again a paramedic backup. Hallucinogens, these alter your sensory perception. And I'm going to go through this one pretty quick because we don't see a whole lot of those as much as we used to. But as far as like mushrooms are concerned, what you're going to see now is your ketamine, your special K. LSD is older. PCP and mescaline is also there. And you have those are our synthetics, okay? But this can last for 12 hours, but sometimes, usually it's over within a 5-hour or 3 to 4 hour period. So we're going to have tachycardia, mild hypertension, dilated pupils, and they can also have that bad trip. And sorry about that, guys. So when they take these hallucinogens, usually within about 30 minutes of ingestion is when they're going to get it, and they're going to start having this issue. With ingestion, we worry more about nausea and vomiting, mild tachycardia, mild hypertension. So worry about that one. With your angel dust and PCP, you can have that smoked, snorted, it can be injected, it can even be eaten, to be honest with you. That's not in the book, but it can be. You're going to have slurred speech, staggering gait, tachycardia, hypertension, and sometimes they just stare at you. They may have horizontal nystagmus, and that's that movement of the eyes, and it's like a rhythmic movement back and forth. They may even have some muscle rigidity. And a hallmark of the PCP use include mind-body separation related to hallucinogens and even violent outbreaks. So that's something else. Ketamine, though, this is the club drug, right? Special K. It's colorless, odorless, and it's usually found in a powder form. It is mixed in drinks. It can be snorted. It is a dissociative drug. Users present with mild inebriation, dreamy or erotic thoughts, and increased sociability. So you're going to have somebody who just wants to be all up on somebody at the club, having fun, touching and dancing and talking and doing the whole 9 yards, right? In higher doses, we may have a little bit of nausea. They may have some difficulty moving around, and they may even say, like, I'm hallucinating, I'm in somewhere else, okay? Like an out-of-body experience almost. Okay. And then mescaline, that's like your peyote. And this is obviously a hallucinogen. Also, a lot of vomiting here, and it's definitely a psychedelic thing. Hallucinations, distortions, out-of-body experiences, and this was used by the Native Americans for, it's in their peace pipes and stuff. So they use these for a medical reason years ago. That was part of their religion. It still is. Treatment, primarily supportive. We're going to limit sensory stimulation. So you're going to turn down the radio, you're going to turn down the lights, you're going to turn down all of the other things, and just transport normally. PCP and ketamine users, go ahead and give them some O2 and get that IV established. And mescaline and your mushrooms, just ABCs. Worry about your oxygen, vital signs, and transport. Remember, if they've eaten a mushroom, worry more about nausea and vomiting with them than anything, okay? And you may still have to get in touch with a paramedic to give them a benzodiazepine for seizures. All right, sedatives and hypnotics. These reduce anxiety. Hypnotics do produce the drowsiness and sleep. And then you have your sedative hypnotic drugs that function as a CNS depressant. And those are your barbiturates and benzodiazepines. We've talked about benzodiazepines a couple of times today. And that helps with seizures, right? But when you have somebody that is taking this to get high, we're worried about our airway management because it depresses the respiratory, it's a CNS depressant, period. Go ahead and get your paramedic backup, establish that IV. Of course, we're going to do oxygen first and treat for shock with a rapid infusion of 1 to 2 boluses of normal saline as necessary. Make sure you get an EKG too, because, guys, these people can fluctuate very quickly. Yes, Christopher.
She's getting aggravated at me, y'all. Also, Does anybody else know when you will see that horizontal nystagmus in somebody's eyes?
Yes,
So,
but I'm gonna let them answer it.
so when you see it, don't just assume that you know what it's from. That's why, even though you see it, you need to make sure that your patient's taken care of. And if you also have this patient that has that horizontal nystagmus, you will see it. You will also potentially have that fruity breath, the fruity smell coming from them. A lot of times that is in your alcoholism. You're maybe somebody that's under the influence of alcohol, but you will also see that in them. So just because you see that, don't be like, they're drunk. They may be, yes, but don't just assume that because you can get burned and trying and accidentally skipping over that they may also have that drug that's in their system. That's it.
Thank you, sir. Appreciate you. Okay, so let's go over cardiac medications. Now, there's a ton of them. You have your antiarrhythmics, beta blockers, calcium channel blockers, and you guys can read about the rest of these, all right? Some of these overdoses, when you have these, are going to be accidental for the most part. What are some of these signs and symptoms of overdoses? We're going to have our hypotension. They're going to be confused. They're going to be weak. Nausea, vomiting, rhythm disturbances are the biggest ones. So we got to get that EKG on them immediately. And we have to worry about bradycardia and our heart block. Headache is another one, and difficulty breathing. So what do you think some of the things you're going to do? Obviously, we're going to worry about our airway. We're going to provide adequate ventilation and administer high flow O2. Obviously, we're definitely getting our A's and our B's taken care of. And then we're going to worry about our C. Now we're going to go ahead and get our vascular access. And if there's an antidote available, we'll get that to them. Of course, you're going to get to the hospital before you're going to get that. But go ahead and get in touch with a paramedic backup. Get them with you, because the likelihood of them taking multiple medications is something that you have to worry about also. And so get that paramedic back up there, get them ready to help you, and just get that, establish that vascular access and contact med control, of course. Other medications, there's several of those. Okay, we have ED meds. They're the most dangerous because of the various drugs that increase sexual gratification. And you're going to see that's Viagra, Cialis, Levitra. I think there's like maybe one more out there right now. But what that causes is hypotension. So if you give them, if you take a handful of ED meds, you're going to have somebody who can go into cardiac arrest. It's really not good. Tricyclic antidepressants, those are people that take TCAs. They like to overdose on these guys. And so you're going to have that altered mentation, confused, drowsy, dysrhythmias. You're going to have dry mouth, blurred vision, urinary retention, and constipation. Of course, those are later on, but you're going to have pulmonary edema pretty quickly. But the most serious ones, you're going to look for VTAC, hypotension, respiratory depression, and even seizures. So obviously, we're worried mostly about getting that airway taken care of, high flow O2, vascular access, and manage that hypotension with sequential boluses of normal saline for these guys. Definitely get your paramedic backup en route. Get your activated charcoal ready. If they are able to maintain their own airway, then we're going to go ahead and give that to them, right? And we're also going to assess blood glucose levels at this point, because our patient could be hypoglycemic. So MAOIs, they can precipitate a hypertensive crisis if taken with tyramine-containing foods. These people already know what they can eat and what they cannot. You guys go look up what tyramine-containing foods are, because that's another 10 minutes to talk about. Your early signs and symptoms include your hyperactivity, dysrhythmias, hyperventilation, and nystagmus. And that occurs 6 to 12 hours after ingestion. And sometimes it can be as long as 24 hours later. No antidote is available, guys. Establish and maintain our airway, breathing. Go ahead and give them oxygen, obviously, and consider your activated charcoal. And go ahead and establish the vascular access if necessary. And if seizures occur, of course, we're getting our paramedic backup because they're going to give them a benzo. SSRIs, a lot of people take SSRIs for managing their depression. So your patients may be asymptomatic to begin with, and then they might have the nausea, vomiting, dysrhythmias. You guys can read all of these, but these are, this is where this patient is deteriorating very fast. What's our care? Same thing as it was before. ABCs, and we're going to be really worried about that. and establish our vascular access. Also, get your paramedic involved and then go ahead and worry about getting some activated charcoal. Remember, we got to call med control for that though. Lithium is another one. This is big for bipolarism, and you're going to see a lot of people with this. It is excreted very slowly, so the toxic levels and overdosing is always present. It is always there. They have to go in and get their levels checked all the time. So signs and symptoms: nausea, vomiting, hand tremors, excessive thirst, slurred speech. Once again, here we go, same thing again. ABCs, it does say insert an advanced airway as needed naturally, and administer our high flow supplemental oxygen and get our vascular access. A lot of these are going to be the kind of that same thing. We're going to transport and go from there. And of course, if they're hypotensive, we're going to give them a bolus, right? NSAIDs. Now, this one's the real bad one. It is most of the problems involve long-term use, but some people, if they try to commit suicide and they take this, they're going to have some pretty bad issues later on down the road. But you're going to have a headache, altermentation, behavioral changes, seizures, and you guys can continue to read hypotension though. Those are big ones. So what can we do for hypotension? We can go ahead and start that IV, right? But we're going to make sure and maintain our ABCs, worry about an airway as necessary, administer our boluses of normal saline, and if it persists, if their hypotension persists rather, sequential fluid boluses, and go ahead and get your paramedic backup. All right, so let's see. Salicylics. That's going to be like your aspirin, over the counter aspirins. There are no antidotes for this or antagonist available, so it's primarily just supportive. And then your acetaminophen is going to be the same. It does have just a few side effects. Antidote should be given less than 8 hours after ingestion, and you can think about, of course, we're going to go for ABCs. Of course, we're going to initiate an IV, and of course, we're going to think about our activated charcoal. Okay, GHB. This one is the one that is the club one where there's a lot of sexual assault. They just put it, it's an odorless and colorless liquid. Of course, they'll put it in drinks. It may have some sort of a saltier taste, but that's pretty much it. And so what does it do? It produces this hypnotic effect, and they're just passive. They have anterograde amnesia where they're not going to remember. With patients that have this, there's multiple things going on with this patient. First off, if you think that this patient has had a sexual assault, this is a different lecture, but we're going to go into it now because we're here. So if you feel like this patient has been sexually assaulted, then you need to take precautions for that too. You need to make sure that if you see that they have bloodied fingers because they've been scratching someone, of course, we're going to get a paper bag and put it around their hands. We're going to do what we can. We're not going to ask a whole lot of questions if they're awake to even ask, right? But there's a whole bunch of different things that you have to think about besides just what's going on with the patient. Now, at no point should that supersede taking care of the ABCs. But this is the afterthought, all right? As you're dealing with these patients, after you've maintained our airway, you've inserted an advanced airway, you've bag valve mask, you're giving them a bolus of normal saline. At this point, when you look down, you're like, oh, wait a minute now, there might be something here. We worry about that, right? Organophosphate poisoning, you're going to see that a lot, like in Mississippi Delta is big on those, okay? Diazinon is a big one. And I see that used in agricultural areas so much. And so it's commonly considered like a nerve gas, if you will. Organophosphates are considered cholinergic agents, and they overstimulate the normal body function that's controlled by the parasympathetic nervous system. So you'll have something, dumbbells is one of them, but you'll have salivation, mucus secretion, urination, crying, abnormal heart rate, and you guys can look up what dumbbells is in just a minute, but it often, so what do we do with this one? Let's go to the next page. Sludgeums and I knew I was forgetting one of them. Sludgeums, that's my favorite one. So anxiety, restlessness, headache, dizzy, confusion, tremors, seizures. Seizures is the big one, but respiratory depression, you're going to have that along with dyspnea. And so sludgeums, salivation, lacrimation, urination, defecation, emesis, and muscle twitching or meiosis. And alternatively, you have diarrhea, urination, meiosis, and that's where you have that constriction of the pupils or muscle weakness, either one. Bradycardia can also be bronchospasms, bronchorrhea, and emesis, lacrimation, seizures, salivation, and sweating. Dumbbells covers a little bit more than sledgem, just for future reference. Treatment, decon, absolutely first. You got to get all of that stuff off of them. Get them out of their clothes, wash it off, put all their stuff in a plastic bag to be disposed of as hazmat. Try to get them scrubbed with soap and water. And once you do that, maintain our airway, advanced airway as necessary. Naturally, you're going to do your high flow O2, vascular access, and we're going to definitely get our paramedic en route for this one because we have got to monitor their EKG very closely. And we're going to go to the most appropriate, closest appropriate facility, guys. Now, we do have an antidote for this, and that's 2-PAM and protopam. It's in our Mark 1 kit. And so you may have that also. Not on the truck. That's not going to be on the truck. It'll be in the ER. So CO, most fatal poisonings. Of course, we understand what that is. CO prevents RBCs from carrying oxygen. It has a 16-time affinity to it, as a matter of fact. It's really difficult to see it in the field or to be like, oh, that's what that is, because you can't smell it, obviously. Some of the things that you will see with CO2 are going to be signs and symptoms like they're going to be very red. They're going to have headache, nausea, vomiting, things of that nature. And they're going to have 100% on their pulse ox, but they may be dyspneic. They may be agitated, things of that nature. So high flow O2 is our very first real thing that we're thinking of when we're talking about our CO2 poisoning. But of course, the first thing we do is get them out, of course. Airway, high flow O2, and then get your vascular access. Keep them quiet. Monitor their level of consciousness, make sure they don't go out. They may even have to get hyperbaric oxygen therapy to help with this, just so you know. So when you transport, you're going to an appropriate facility that might have that hyperbaric chamber readily available. And consider possibility of combined CO cyanide poisoning also, especially if their patient has a sign and symptom of shock. Metals, there's lead, and that can be in a whole bunch of different places. They found them in the bottom of the Stanley Cups, right? That's a new thing. Headache is a late sign. Yes, thank you, Chris. And thank you for the question, Joshua. Okay. Usually when you have the inorganic lead, it's going to be ingested or it can be breathed in. But once in the body, approximately 90% of the lead is stored in the teeth and bones. It's an excretion. The half-life of lead in the bone is estimated at 30 years, you guys. It's crazy. Iron, that gets in your GI, it becomes toxic in your GI tract. Systemic toxicity too, and there's little you can do in the field. Just get them to the appropriate facility. And of course, all of these are going to be ABCs, establish an airway, breathing, circulation, establish an IV. Okay, miscellaneous. Okay, I don't know what ALOC is with metal poisonings. Tell me what that means, Lindsay. Okay, chlorine gas. It's a whole bunch of places that you can find chlorine compounds, and it's going to be burning in your eyes, nose, and throat. Cyanide, you're going to find that in face palm, altered level of consciousness. Okay, the cyanide's also going to have an altered mentation as well. Thank you, Joshua. I saw Mark put up the peace sign, so I figured he was out for a call, so thank you so much. Caustics, chemicals used in industrial areas, agricultural areas, even your home. It's going to have severe pain in your mouth, throat, and chest. And there's a whole bunch of different things that can be done here, but you're going to get them to a hospital to help them, especially with like cyanide. Gosh, what is that called? Amyl nitrate for cyanide. You're not going to find that on the back of the truck. That's going to be in a hospital. So there's a whole bunch of different things that you're gonna need, but you're not going to be able to get it until you get to the hospital. Call for paramedic backup. Once again, every single one of these are the exact same, guys. It is going to be ABCs, and be aggressive with the ABCs, guys. Establish an IV, call for paramedic backup, get them to the appropriate facility. Methyl alcohol and ethylene glycol. That's like more of your antifreeze stuff, and that's going to cause tachypnea, blindness, renal failure. And then your hydrocarbons, those are going to be like more of your household products, and those cause respiratory distress and sudden death. Remember, if it's a hydrocarbon, you cannot give them activated charcoal. Food poisoning, Hey, when you got a couple people that are at the same place, they're sick at the same time, and they're just throwing up all the time, hey, restaurants, cafeterias, delicatessens, hey, it could be bluebell again. Who knows? Some of the toxins that are obvious, you have your salmonella, listeria, and toxoplasm plasma. And that's about roughly 35% of food related deaths are from those. Abdominal pain, cramping, nausea, vomiting, diarrhea. What do you think we're going to do? Same thing we've done the entire chapter. We're going to do ABCs, establish a vascular access, administer fluid for hypotension, and go ahead and get ready because you may have to have a paramedic backup. I do want to, hold on, I saw it just a second ago. Hold on. Okay, so if you have improper food storage, you can get Clostridium botulinum. Okay, this doesn't just kill you or can kill you, it also does a whole bunch of other stuff. It can even paralyze you at the end of it. And some of these are red tides. You have dinoflagellates, are called red tides, and they're in shellfish such as oysters, clams, mussels, and they can cause paralytic shellfish poisoning. So when we talk about food poisoning, there's a lot of stuff that can happen, and that it doesn't, some of it doesn't just kill you guys, it can change your entire life. Poisonous plants, few plants are poisonous. I still don't tell anyone to go out and pick the berries off of anything and eat them. Just don't do it. Most plant related deaths are going to be from children under the age of 6. But deaths from plants are rare. Dieffenbachia and castor bean seeds can definitely be deadly. You have table 23-5 that has a whole bunch of toxic plants. Remember, call your poison control center. And here's some pretty pictures. The first one is Dieffenbachia, and a lot of people have that. Mistletoe. Our castor bean is the next one. Nightshade. I've never seen nightshade in real life, or foxglove. Rhododendron, jimsonweed, and death camas. It's called death camas. Commas? I don't know. It's called death something. Y'all don't mess with that one. Let's not eat the one that's called death. The next one over here is poison ivy. That's really bad for a lot of people. Poison oak is the next one. You have pokeweed, rosary bead, or I'm sorry, rosary pea, and poison sumac. If it's red and it's in nature, don't eat it. Okay, unless you know that it's okay, like a strawberry. All right, guys, let me stop the recording.